women with future risk. So if you stay with me through today's talk, I want to first ask how many of you actually screen women? How many of you are actually doing the screening? And those of you whose hands are not going up, I will also say this impacts all of us. It impacts wives and sisters and friends and mothers and young people, because we can do better. And that's part of the reason I'm so passionate about this. We have the tools and they're underutilized. They're inappropriately utilized. So as I go through my talk today, and I am from Michigan, and I want to say to our AV guys, thanks for all the Motown. And the leaves are falling rapidly from where I come. So I'm really going to enjoy this evening in beautiful San Diego. It's beautiful in Michigan, but we know what's coming. So disclosures, I am on the advisory board and speak for Hologic. As far as learning objectives, what you see here is it's really important to understand the role of persistent HPV in the development of neoplasia and cancer. HPV testing, use of HPV primary screening. So the new thing on the block is we now have FDA approval of a standalone HPV test. Instead of a PAP, it is doing a PAP not as with an HPV test, but doing an HPV test alone as the first test. So cervical cancer screening, it's important to know that the PAP test is not a diagnosis. The PAP is a screening test to identify women who may have high-grade precancerous change to treat. We want to avoid unnecessary treatment. You know, the guidelines have changed dramatically. We now know that young women have almost no cancer, but have a significant prevalence of HPV infection, most of which is transient and will go away. We want to minimize costs to the healthcare system. So the bottom line in cervical cancer screening today is increasing benefit and decreasing harm to women. So who are the women who get cervical cancer in the United States? Being rarely or never screened is the largest group, the majority of women that have cancer deaths of cervical cancer. Who are those rarely and never screened women? And this includes minorities and foreign-born women, women without insurance, underinsured women. And we know that in the United States, we have had, how many of you remember, and maybe still today know, how we've used to dangle the PAP like a carrot? You can't get your pills until you have a PAP. How many still here, even though I instruct the people in my office otherwise, are still hearing women being told, schedule to see Nancy for your PAP. Schedule your PAP. The PAP is but a small part of a women's health visit. It's not the whole visit. And we need to continue to educate women that a PAP and HPV test may or may not be done based on the last time it was done, based on results, and so on. I had the opportunity to be in Cambodia, and right down the block from my hotel was a clinic. And I had a lovely young woman show me through the clinic. When I saw the antiquated exam table in the 40-year-old ultrasound machine, I was taken aback and again realized how much we have in terms of resources in this country, but they're underutilized. How many young women and young men are not being vaccinated for HPV? How many are not completing the series? We have HPV testing was approved as a co-test along with the PAP in 2003, and the adoption has been very slow. So whether you are counseling women before they are screened by PAP or PAP plus HPV, or in the future, if you do HPV standalone, or whether you're counseling a mother about why her children should be vaccinated, or why you're counseling a partner, a male, or a men who have sex with men, we need to understand the basics, the foundation of HPV natural history. So I'm going to run through, and it may be review for many, but we need to understand this foundation. Virtually all cervical cancer is caused by HPV. There may be a very small percentage that are not HPV initiated. We have that data. We know that HPV 16 and 18 cause the majority of cervical cancer, with HPV 16 causing the majority of squamous, and HPV 18 the majority of adenocarcinoma. We know there are low-risk types of HPV. HPV 6 and 11 cause 90% of genital warts, and those types are included in the HPV vaccine, but we never test for low-risk HPV because it's not important in any cancer prevention strategy. So here we are in a country with resources, and in the US, there are still every year more than 12,000 diagnosed cases of cervical cancer. Worldwide, it's a much bigger problem with the lack of screening without pathologists who can read Pap tests. There is an HPV test that's been developed that does not require electricity or running water to be done. Identify those women who may have precancerous changes and benefit by treatment or have an existing cervical cancer. So I mentioned HPV 16. That is the player, that is the bad guy. We are seeing emerging data of the role of HPV 16. It causes 90% of anal cancer. And anal cancer is on the rise. And I don't want to forget to mention that it does not require anal intercourse to have infection by HPV 16 in the anal canal. We see that HPV 16 is an initiator or a causative agent in cancers of the head and neck. And I want to give just a real quick overview of transformation zones, something that I tell my patients because there are questions as to, for example, if I have HPV, does my partner need to be seen? Does my partner need to be tested? We know that HPV is ubiquitous. Most everyone's infected at some point. Most everyone clears the virus to undetectable levels. Squamous epithelium, which is mature squamous cells, not changing, put HPV there, let it persist. Cancer is rare. Neoplastic change and progression to cancer is pretty rare. But transformation zones have the unique problem of metaplastic epithelium. Metaplastic epithelium is developed in areas of the body where one cell type abuts another. It happens on the cervix where glandular cells meet squamous. And due to the acidity of the vagina, with lactobacilli bacteria making hydrogen peroxide, there's burning of the villus tips of glandular cells, there's a process of metaplasia, proliferation of basal cells, cells from the basal layer, in this change process of metaplastic, which over the female lifespan on the cervix, the area where squamous meets glandular moves proximally into the canal throughout the female lifespan. That area of change, metaplasia, put HPV there and have it persist, and those are the cells that have great risk of becoming neoplastic and progression with persistence. The anal canal has a transformation zone. The tonsils have a transformation zone. So we have the model, and I like to think of this as a transformation zone with metaplastic epithelium, and the soil is infected by the seed, HPV. So we have to be concerned. Most everyone's infected by HPV, but why don't men get routine screening? Of course, the external genital skin of the male is mature squamous epithelium. But the anal canal, there's still a lot of data being identified, and right now we do not have routine anal screening. There has been studying about should women who've had precancer of the cervix have an anal cytology. Men who have sex with men is one population where anal cytology is currently recommended. But the Pap test from the anal canal has to be read by a specially trained pathologist. And a positive screen leads to high-resolution anoscopy, or HRA. And if any of you are interested or work in HIV populations, there is you can go to courses and learn HRA if it's something that interested you, and it is taught by the fairly new Anal Intraepithelial Neoplasia Society. Did you know there was a society for that too? So AINS is doing education and is available. So I can't stress enough, this is about everyone's infected by HPV. Most everybody clears. The virus is usually cleared by an immune response on the average 8 or 9 months. The majority cleared by 24 months. Clears, and that's who we're looking for. We're trying to identify women who got infected, never cleared, and if they have persistent HPV, and particularly 16 or 18, they have risk for cervical cancer. So I've mentioned that to clearance is considered a relatively short time. So why is HPV so important? We think about US white male smokers and their risk of lung cancer. Well, that's 8 times higher than the non-smoker. Risk of breast cancer with hormone therapy is 1.8 times. But if you have persistent HPV-16 in the cervix, you have a 450 times greater risk of developing cervical cancer. So this is, in review, what happens. The normal cervix gets infected by 1 or more types of HPV. Over time, that infection may persist, or in most cases, regresses. It gets cleared. And what does clearance mean? What does it mean? And your patient says, I was positive, now I'm negative. What does that mean that I cleared? We don't know exactly what that means, but the HPV tests on the market are set to find clinically relevant levels of infection. We don't want a PCR test that picks up a level of virions that is so low that it's not significant for the development of disease. We know that there are women who may be positive, become negative, and then go positive. How do you explain to the woman who's monogamous? You've been co-testing her, and under guidelines, PAP plus HPV co-testing is every 5 years. She was negative, and now she's positive on her HPV test. How do we explain that? Does she need to go home and throw out her partner? No, absolutely not. And it may be, I had an interesting case of a woman who developed actually external exophytic disease. She actually had an HPV-related change of the perineum. And when I talked with her and took her history, I realized she was being worked up for an autoimmune disease. She might have had lupus or some other autoimmune problem, and perhaps this really old infection, she was monogamous, no change of partner, this really old HPV infection that had persisted was now able to be productive and show, I think at the time she had some external genital warts, again, caused by HPV 6 and 11, but cancer potential. But this is an example where her immune response may have changed and allowed for this productive infection. But if HPV persists, there can be progression to precancer. This is what we're screening for. We don't want to find low-grade disease that mostly goes away on its own. The old guidelines, remember when we used to do the first PAP at the onset of sexual activity? Then it was age 18, and then it was 3 years after first intercourse. And the reason that changed is the data supports the fact that from here, precancer to invasive cancer takes 10 to 15 years. Not overnight, not in a day. We have time. We have time to find the precancer. And that's what we're looking for. We don't want to find low-grade disease, and especially low-grade disease in young women, women who have not completed their childbearing. Though the risks of cervical treatment are low, they're not zero. There can be problems with cervical competence into the future. So we are going to screen all women. We don't take a sexual history to determine who should be screened. we screen all women because everyone has potentially been HPV infected, and we want to find those who are persistent. The risk factors. I've been in practice a long time, so I've had the historical perspective, and don't you just love it? Those of us who've been in practice a long time, we see how we learn things, long-term use of medications and various changes. We used to say you can't ping-pong HPV back and forth between partners. But we don't say that anymore because there has been a study published by Weiner in the New England Journal that suggests that a condom used by a partner does reduce the persistence of low-grade disease, that women whose partners used condoms have more regression of their abnormal cervical changes than women who don't. So we do recommend condom use in terms of HPV. If I have a young woman with a low-grade lesion, it may make sense then to tell her to use a condom even with her long-term partner. But again, we can reassure that couple and say that if a woman is diagnosed with an HPV positive test, with an abnormal pap, with a lesion, a vulvar lesion, we can reassure that the male doesn't need screening. If there's an abnormal change of neoplastic change on the mature squamous epithelium of the male externally, it is visible to the naked eye as a red, white, or pigmented lesion, and you don't need vinegar to see it. So HPV vaccination, just again to make a point that it's underutilized, and I find the opportunity to piggyback messages. When I see a woman for her routine annual exam, and when I explain why I'm testing her for HPV, it's a good chance to say, and oh, by the way, you have teenagers, you have a son or a daughter who's under 26, has that child been vaccinated? It's a great opportunity for piggybacking messages. And of course, the guidelines for vaccination have changed. We all know that the most robust response to the vaccine is in 11 and 12-year-olds. That's why we want to get them. We know from guidelines that we may vaccinate even young women who've already had treatment of cervical disease because the data showed us that when women are vaccinated, that it is rare that they've been infected by all types in the vaccine. And now we have the 9-valent. So the vaccination, I really encouraged, we need to try to have young people get it and complete their series. Now, under 15 years old, it is now 2 injections, but over 15, the Advisory Committee on Immunization Practice still recommends 3 to complete the series. So what's to know, what's new, what's changed? We now know then we can prevent cervical cancer through vaccination. We have improved screening through the detection of high-grade precancerous lesions with the addition of HPV testing. So there are 4 parts to screening. We want to do cytology with or without an HPV test, standalone HPV testing, which I'm going to spend some time on this afternoon, and then we're going to evaluate those screen-positive women, realizing again that the PAP is not a diagnosis but a screening test. The PAP has problems. It's subjective. It's said if you give the same PAP before lunch and after lunch to a pathologist, the pathologist might say ask us before lunch, but after lunch might say negative, ask us, don't ask us. But this is the problem. Cytology is subjective, and we want to treat women's precancerous lesions. So most of you are familiar with the 2012 guidelines for cervical cancer screening. We were so happy that everything, the planets aligned, ASCCP, the American College of Pathologists, and the American Cancer Society, and the U.S. Preventative Services Task Force all aligned, and everybody's been quite happy about that. But I want to bring to your attention that the U.S. PSTF just closed down in the last 2 weeks a public bulletin board of a draft of new cervical cancer screening guidelines. And those guidelines are controversial. And I will come back to that, but the U.S. Preventative Services Task Force put up this month, the guideline is a PAP every 3 years. We do no longer, U.S. Preventative Services Task Force says, we do not any longer recommend co-testing PAP plus HPV and recommend standalone HPV testing every 5 years. And this is pretty radical. And this is, there was a lot of support from the ASCCP, American Cancer Society, and others in not changing the guidelines, in supporting the guidelines that we have. And these guidelines were based on significant amounts of data. Most of the data we have comes from the ALTS trial, which was the biggest trial and a very large trial done in Costa Rica. The ASCUS low-SIL triage study brought forth much of our information and utilized the original HPV test, the hybrid capture, which became the hybrid capture 2. And those of you who screen know we now have 4 HPV tests on the market. And those of you who use an HPV test, how many of you know which test you use? Does anyone know? So I see just a hand go up. How many of you are doing HPV testing in practice? So I encourage all of you to go home and figure out which HPV test your lab is using. Or maybe you have multiple labs. I have my patients' specimens go to 2 different labs, and I have 2 different tests. But I want you to know the difference in the tests, and I will come back to that shortly. So the guidelines, as you know, today are first PAP age 21. And this is regardless of sexual history or age of sexual debut. It doesn't matter when you say, but I work in a high-risk clinic where young women are pregnant in their teens. Doesn't matter. Doesn't matter. High risk doesn't change the guideline. Why? Because, again, back to the SEER data, that there's almost no cervical cancer in young women. It takes 10 to 15 years from precancer to invasive cancer in those women with persistence, particularly of 16 and 18. That's why we have time, and that's why we need to leave young women alone. So the guidelines align, PAP every 3 years, 21 to 29, preferred for women 30 and older is co-testing every 5 years. I started co-testing the day after FDA approval in 2003. At that time, it was every 3 years, but based on data, it became every 5. It's important to know that the age of starting co-testing at age 30 was based on data at the time. The data showed us that the age where the greatest number of women have HPV infection is the mid-20s. But that starts to drop down as women have less new exposures. Cervical cancer prevalence in the mid-40s and goes up. And where those lines cross is about age 30. That's where, and I explain to my patients, old persistent infection, one that you haven't cleared. We're not looking for new infection. We want to find old infection where the risk of disease is great. For women 30 and older to have a PAP alone every 3. And again, the USPSTF was aligned. Everyone was so happy. But now we have a major situation. Because what if they adopt and stick with this new guideline? Will it impact insurance coverage? And one of the concerns, it's not about HPV test standalone, it is the 5-year interval. So we have 1 HPV test is approved now for standalone testing. And that is the COBAS test. So only 1 of the 4 is currently approved for standalone HPV testing. And I'm going to give you more detail about that. But just a reminder that these guidelines do not apply to high-risk women, HIV-infected, immunosuppressed, DES exposure. Interesting, in DES women, that transformation zone, that area of metaplasia, can extend into the vaginal fornices, and that's the adenosis part. Again, remember the seed and the soil. HPV, persistent, there's a wider area of potential disease that can be found, and that's why those women need Pap tests that are taken out further. Take that spatula out into the vaginal fornice. And when you're doing a Pap test, when I talked about the transformation zone, mature squamous epithelium is pretty contiguous and the surface is pretty smooth, but the immature metaplasia and glandular epithelium is pretty red and can bleed easily. So you know that if you have a young woman with a really immature transformation zone, you need to get that spatula out there because that's where disease occurs. Most abnormal lesions occur at the squamocolumnar junction where the squamous and glandular meet. So in DES women, there was a prevalence of clear cell carcinoma in the vaginal wall, in the vaginal fornices that peaked at the age of about 19 in DES-exposed women. But now those women are becoming in their 60s, where the typical natural history of that cancer is that it occurs in the 60s. So we need to follow those women. If a DES woman comes into your practice, she needs a good pelvic exam that includes feeling into the bilaterally into the vaginal fornix, and she needs often to extend that spatula out. So the guidelines, and what about stopping cervical cancer screening? You may know that we now are told we may exit women out at 65 if there's been 3 negative Pap tests or 2 rounds of co-testing in the previous decade and no abnormal. The one thing I want to point out to you that is not in the algorithms that are in the phone app and pocket guide, but if a woman, and I've had these women, if a woman comes in and I say, guess what, you get to graduate, you're 65, you've had negative screening, this may be your last Pap and HPV, and the result comes back ascus, atypical squamous cells of undetermined significance, but the HPV is negative. But the data shows that the risk of CIN3 plus is greater in those women with an ascus HPV negative than in negative. And for that reason, those women need an accelerated repeat screen in 12 months. Another Pap plus HPV, if she's negative, she can be exited out. In screening post-hysterectomy, don't you just love the women who, and we know this, women don't know what a cervix is, let alone whether they still have one. So we know that, and I find women as recently as this week. I had a woman who was so sure that she had a total hysterectomy. And what does total hysterectomy mean? It's a lay term. Women, we know what they mean. Partial hysterectomy, total, whether or not I still have ovaries. But it really doesn't refer to ovaries at all. And there's been a trend in this last decade to leave the cervix behind, the supracervical hysterectomy, for reasons of continence and sexual response and prevention of prolapse. There's been some data suggesting. So we need to look and see if there's a cervix. This woman I just had this week hadn't been screened for 12 years because she is not a person who likes to go see medical professionals, and her husband, who is a physician, said, oh, if you don't want to go, you don't have anything anyway. Well, she had a cervix, so fortunately, her Pap and HPV just came back negative. And she, by the way, had what she called precancer in her past history before the hysterectomy, so there was some anxiety waiting on those results. So the role of all professionals, advocate for evidence-based guidelines, and in doing so, avoid overpopulation. Follow guidelines, and this is a quote I just love, because going back to the photo I showed you in Cambodia, a lack of resources, but in this country, we've overtaught women. And how about myself? I told you I've been doing co-testing for 14 years. And when we co-test, we are reassured that woman doesn't have disease now, or has the risk is negligible for disease in the future. But let me tell you how hard, even to this day, When the vial and the spatula and the endocervical brush are sitting right there on the counter, I practically had to tie my arm down, you know, to not take the PAP and HPV for some years. But that's why it's helpful that our patients they have records of what they had and when, and patients are transient, and we don't know, you know, nobody's going to arrest you if you repeat cervical screening and it's only been a year or two because you don't have the results and the patient's not sure. We have to use clinical judgment. So what happened to the well woman visit? As I say, we need to unteach women about annual cervical screening. It's not the dangling carrot that you can't do this or that until you get a PAP. We need to unteach women and help them understand screening for cervical cancer is something we do based on guidelines, based on past history. In the annual exam, we need to make sure women understand it's about bone health and vaginal health, breast health, and so forth. So July of 14, a huge retrospective study saying that there is no evidence for doing an annual pelvic exam in asymptomatic women. But of course, the American College of OB-GYN, knowing this was coming the day before, June 30th of 14, put out an advisory supporting the annual pelvic exam. And I do explain to women that there is a chance that I have to look at the external genital skin. Melanomas can occur there. It's a chance to look at, we know that elderly women are often found with squamous carcinomas because they haven't been examined. Women with entities such as lichen sclerosis, where they haven't been examined and there is some risk of cancer there. It's a chance to find prolapse women are embarrassed to talk about, to find things that women have not been comfortable mentioning, that they have incontinence and so on. So we do need to communicate with our patient about what we're doing and why. And I even give an option when I do my pelvic exam. I always ask my patient, is it okay if I do a rectal exam? And once in a while, women actually do refuse, and I think that's their right. So I'm going to run through HPV testing. I've talked about it a bit. I've referenced it. But I want to just delve in and tell you, why test for HPV? I mentioned that its greatest strength is its negative predictive value. When we tell a woman her PAP was negative, normal, your PAP was normal, what does she think? She says, great, I don't have cervical cancer. But we know the PAP can miss disease as much as 50% of the time. Okay, so unlike the HPV test, which in studies approaches 100% accuracy. So if your HPV test is negative, I can reassure you that there's very, very negligible risk that you have disease now or that you have risk in the future. We can find women who are negative and need less surveillance, and we identify those women who are truly at risk and need to be followed diligently. Debbie Saslow from the American Cancer Society says providers can rely upon the negative predictive value that these women are at such low risk. So there are 4 tests on the market, and only one right now is approved for primary standalone. Why would we test for HPV alone? What other scenario is there where we do, or I should say don't do the most sensitive test first? If we do a VDRL, we get a reflex to a more specific test. If we do an HIV test, we have reflex to specific test. But the PAP is not the most sensitive test. It is more specific, but it is not real sensitive. It's a great test. It has reduced cervical cancer in this country during its existence by 75%, but we're still missing cancer. So the test that was used for the ALTS trial that's been around the longest is the hybrid Capture-2. The hybrid Capture-2 gives you a panel, positive or negative, for 13 types of HPV. Cervista, high-risk panel for 14 types of HPV. But if the test is positive, remember it's just positive, you can ask for genotyping for 16 and 18. It's an add-on test. The COBAS test, this is a panel of 12 types, and 16, 18 genotyping is reported every single test. Aptima RNA is also a panel of 14 types, but if positive, you can ask for genotyping for 16 and 1845. So if you get a result back, since almost nobody knows which HPV test they have, if your HPV test comes back and tells you that there's a 12-type panel, positive or negative, and 16 and 18 every test, that's the COBAS. And that is the only test currently approved by the FDA as a standalone primary screen. So we're talking about the patient comes in and she only gets an HPV test. And I'll be going through that algorithm with you. But as you know, co-testing PAP plus HPV, if both tests are negative, she gets repeat co-testing in 5 years. This is what the U.S. Preventive Task Forces just put out a draft saying, we don't support this. But this has been, for most of us, this has been the incredibly important and improved cervical screening tool that we've had to open from a small peephole to a huge window on risk. And this is what we may see go away over time if insurance companies get involved. So with this strategy, if the patient has any ascus, if the HPV test is negative but she has a borderline abnormal PAP ascus, she gets co-tested in 3 years. Any abnormal PAP worse than ascus is colposcopy, and a positive HPV with any LSIL or greater is colposcopy. What we're looking at, though, is what do we do with the HPV positive PAP negative women? And now we have two choices. We had the choice before genotyping. If you're PAP negative, HPV positive, we don't know yet if that's a persistent infection. So the data suggested the best strategy was repeat both tests in 1 year. Then, if she's still positive HPV, even if the PAP is still negative, colposcopy. But what's been added is if you have access to genotyping and you can find out if she's positive for 16 or 18, those women have a higher risk. That's a subset of risk that those women need to have immediate colposcopy. So I've talked about genotyping, the importance of genotyping. We are now taking a subset of women who are not just HPV positive, but they truly have a high risk for progression to invasive cancer over time. So at the 12-year follow-up visit, those women who are negative on both tests repeat co-testing in 3 years. She's gone from positive HPV negative PAP to negative HPV negative PAP. We repeat co-testing in 3 years. I'm not going to go through every one of these algorithms because it's all available to you, and I want to get through all of my many slides here. But high-risk HPV testing in the US, it's been used not appropriately and not often enough. But everybody should be doing HPV testing. So the algorithms today, and you have all these slides accessible to you, so I'm just going to hit some key points. We need to understand that young women have almost no cancer and lots of HPV and lots of abnormal PAPs. And for that reason, we have learned to leave them alone. And leave alone means that 21 to 24-year-olds have their own algorithms. We don't send those young women to colposcopy anymore, even if they're ascus with an HPV positive. We don't send them if they're LSIL, low-grade abnormal. They get a repeat PAP in 1 year because most of that will go away on its own. And I want to make just quick mention of what is an ascus PAP. It's equivocal, it's borderline. The pathologist says, I can't quite call it normal, can't quite call it abnormal. I get to put it in this in-between. 75% of women with ascus have nothing wrong. 25% do. And we need to find those 25%, so that's where the triage with an HPV test came in. Because we're going to say those women with an ascus pap who have HPV are the ones who need colposcopy. Those who don't have HPV just get followed up. So that's been going on. What's changed is now as co-testing has become more common, we find out HPV status on more women than we used to. And that has changed. I mentioned again, we're going to be really just leave young women alone, and we're going to give them time to clear. In ascus cytology, I've talked about what we do and the 65-year-old who has an ascus HPV negative. Postmenopausal women in general should be managed the same as other women. One of the most common causes of misclassification to a low-grade abnormal pap is estrogen deficiency. So if I have a postmenopausal woman with an abnormal pap and she needs colposcopy, I'm a colposcopist, but if you refer your patients out, I would love them to be estrogenized with intravaginal estrogen for 3 weeks and a week off before the colposcopy. LSIL and ascus with HPV, there is a risk of high-grade disease, and we're going to identify those women. And the one last thing I want to tell you about these algorithms is the algorithm was always, if the pap is abnormal, LSIL, send that woman to colposcopy. But now because of co-testing, we have the HPV status of many women with LSIL. So now we have 3 different arms of the algorithm. One is repeat, if they're LSIL with a negative HPV test, because you did it as a co-test, she doesn't get colposcopy. She just gets co-testing at 1 year. But if she didn't have an HPV test or she was positive, she gets colposcopy. So I want to talk about primary screening because I don't know if any of you have seen it. I'm not doing it yet. I'm not quite ready. I'm not an early adopter. But it is approved in this country. Primary HPV standalone screening. This means your patient comes in, it's her annual exam, she's due to be screened, you do an HPV test. You collect the pap in the same way you always have, put it in your liquid-based vial, spatula brush, vacillate it, it's in the vial. In the lab, they run the HPV test. Based on that information, whether she's negative, repeat in 3 years, positive for 12-type panel, she gets reflex to a pap. From that same vial, they make a slide and do a pap. But if she's 16 or 18 positive, is she high risk? Very high risk, so she gets immediate colposcopy. This was approved in April of 14. It was approved for women 25 and older. I point that out and remind you that co-testing is 30 and older. That's because it was based on data at the time. Primary HPV standalone is based on data at the time, which was the Athena trial, which gave us most of our information. Only one test so far is approved for standalone, and that's the Roche Cobas. This may change, and the US PSTF in their draft did not mention whether that they said nothing about which test, only the FDA-approved test. They put out that their recommendation for all women is a pap every 3 years or an HPV test every 5. Co-testing pap plus HPV, it's only marginally better than an HPV test alone. Cytology, I've mentioned it's highly variable, subjective, can miss cancer. And we're not sure how it will perform as our vaccinated cohort increases. Because when you decrease the amount of disease in the population, you lose the positive predictive value of the pap. Lesions are smaller because we're protecting against 16 and 18 in that population. So if you look at the performance of cervical cytology, it's sometimes in studies across the board, the sensitivity is as low as 44%. Up to 74%, the HPV test is more accurate. We can see false positive results, the ASCUS PAP, LSIL. We are finding women and telling them their PAP's abnormal when they may not have disease. There's been attempts to improve cytology with computer-assisted quality control, reduced work limits, and so on. Using HPV testing, though, improves screening by balancing benefit and harm. And so many women are infected by HPV at some point in their life, but not everybody clears, and we need to strike the balance of benefit and decreasing harm. Genotyping has really made a change in how we're able to utilize HPV testing and find that subset of women. So this HPV standalone primary came about one study of HPV genotyping over 20,000 women through Kaiser. And I want to show you, if you look at this graph, over 15 years of follow-up. This line at the bottom is if a woman was HPV negative over 15 years, and this is the detection of CIN3+, precancer to cancer. Over 15 years negative, the other 12 types, but if you're 16 positive, you look at what happens up over time of developing precancerous change. So the study that led to FDA approval of primary screening was the Athena trial. And this trial looked at over 45,000 women, so it was a very big trial. In the Athena trial, women were recruited. I'm not going to go through the details, but I want you to see in labs A, B, C, and D, though the median age was quite similar, the ASCUS rate was extremely variable, from as low as 3.8% to as high as 9.9%. The sensitivity of the PAP was as low as 42% to 73%, but the HPV test was much more sensitive. So the risk of CIN in cytology, negative women, this is another way to look at this, the importance of HPV testing, the importance of genotyping. In Athena, CIN 2+ and 3+, HPV high-risk negative women, over time, developing CIN 2-3 was extremely low, 0.9 and 0.3%. But if you look at 16, 18 positive women, 11.7 and 9.9%, we need to find those women with 16 and 18. So the primary screen algorithm in the study knew that there had to be some kind of triage test on those women who had HPV. The other reason that the HPV primary is approved for 25 and older is that 28 or 30% of women who had the precancer in Athena were in the 25 to 29 age group. So this is why the standalone HPV test starts at 25, whereas co-testing starts at 30. So we have interim clinical guidance on primary standalone screening. The rationale I've told you, a negative HPV test provides greater reassurance of whether that woman has precancer than a PAP. And this is where we're heading. In Europe, this is being done. In Australia, starting December 1st, the whole country will be doing standalone HPV as their screening. It's coming in the US. I just think I saw so much pushback on even adding an HPV test. How many of you think you're ready to drop the PAP and just do HPV? So I see a few hands, but that's where we're moving based on huge amounts of data. This is well supported. And this is yet another study showing you this line going up over time and months are the women who are HPV 16 positive versus those women who are negative, pretty flat along the baseline. So the FDA approved this. The rationale, it's more sensitive, reproducible, it's objective. There's no activity. It not only finds women with current risk, we can find those women with future risk and say, you don't have a time bomb waiting to go off. but I'm going to follow you diligently as long as you have HPV. You need colposcopy, you need follow-up treatment of true precancerous lesions. The guidance says rescreening after a negative primary is no sooner than every 3 years. Starts at 25 due to the Athena trial. And the guidance says, and this is published, it can be considered as an alternative to US cytology alone or co-testing. And a lot of that's based on the genotyping. So I want to show you what the algorithm is in the US. Your patient comes in and she's due for screening. She gets a cobas test. You get an information whether this panel of 12 types is positive or negative and whether she has 16 or 18. If she's negative, she's routine screen. What is that? A pap in 3, I'm sorry, old habits die hard. She gets another HPV in 3 years. If she's 12 type positive in the lab, they run out of that leftover liquid that preserves it in the vial, they make a slide and do a pap. If the pap is negative, she gets HPV in a year. But if it's ascus or greater, she gets colposcopy. If she's 16, 18 positive, she gets colposcopy. That's the subset of women who we're going to say, think of that line going up as the months go by. And over the years, she can develop precancer, and we want to find precancer and treat it. What Australia is doing differently than this algorithm that actually will meet the concerns of some in the US is that all women, even those with 16, 18, will have a pap. The concern is that glandular lesions, which sit high in the cervical canal relatively, may be found through a pap. And that is a concern about missed adeno disease, and that's one of the things that we may see change. So the debate continues about screening frequency, but we know that overscreening can lead to more invasive procedures. We do give up, because of the addition of more colposcopy in the standalone HPV, the treatment harms the loss of the competence of the cervix, pregnancy, psychosocial distress, and life disruption. There was a study published through Quest, it's called the Blatt study, that looked at over 250,000 women. This study has had some concern because there were women lost to follow-up, but in the study, the sensitivity for precancer with HPV alone was less at 94% than co-testing at 99%. So there are some who still feel strongly about maintaining co-testing. In a Kaiser study, looking at records of over 300,000, and I'm sorry about moving this mouse so much, the risk of CIN3 after negative screening was 19% with PAP alone, but just 0.7 with the HPV test and 0.11 with co-testing. And that goes back to what data has shown us that the PAP adds very little in terms of sensitivity when the HPV test is done. So you are supported by ACOG on these guidelines that we may stop screening at 65. We don't screen women who had a hysterectomy for benign reasons. Follow-up co-testing at 12 months if HPV positive, PAP negative, and HPV 16 negative. Only use FDA-approved tests. And if a woman is treated for precancer, we want to follow her for 20 years. And when that becomes particularly important is if your patient had a leap at age 55, she becomes 65, she hasn't accumulated 20 years of follow-up yet. So we want to follow women for 20 years. I've mentioned that primary HPV is happening. It's happening around the world, and we'll probably see that continue to grow. So quick case study. Your 42-year-old patient, no previous HPV testing, you screen her, you do a HPV test alone. So she's positive for HPV, and this is not on the ARS. She's positive for HPV 16 and the panel of 12 other types. What do you do? What do you do next? What's the next step? Does she need a reflex to a PAP? Well, under our algorithm, she doesn't. She needs colposcopy because of the HPV-16 positivity. So you're a colposcopist or you're not, and you send her out. Colposcopy is adequate. The squamocolumnar junction is seen. There's no lesion. The ECC is negative. So if she's got HPV positivity for a genotype high risk 16, but a negative colposcopy with a negative ECC. So what will you do next? Where do you go from here? Well, guidelines are meant to increase benefit, decrease harm, but it is complicated, but help is available. And if you don't know, there is available to you on the ASCCP website, the American Society for Colposcopy and Cervical Pathology, ASCCP.